one thing we like to say with our Q&As, the doctors are answering based on their experience. They are not answering as if they have seen your chart and they have been treating you. So when you ask your question, you get a response. Just please remember, you're getting this as what their experience has been with other patients. And then with that.
Very good. All right. I know we had a question from earlier.
Thank you so much. Doctors, in the clinical, in the community dermatology setting, when should a dermatologist go ahead and send the patient for a flow cytometry test? Is it upon the initial diagnosis of mycosis fungoides? Basically, what's your thought process on when they should send the patient out for flow cytometry in the clinical, the community dermatologist setting?
I think different cancer center or different cancer doctor feels about it differently. Maybe oncologists and dermatologists feels about differently. But in my mind, every patient that's diagnosed with CTCL should at least be seen in an academic center at least once to do the complete workup. And that way, if disease progress, we can clearly know, because you know how complicated the treatment paradigm is. It requires oncologists, it requires radiation oncologists, requires dermatologists, and sometimes it requires transplant doctors. So being seen in an academic center once, you get access to maybe potential clinical trial. But secondary is that when things are not going the right way, your doctor actually have an easy access to the doctors at Moffitt, and they already saw your chart. They can talk to you and make treatment recommendation. So I know that that question came up earlier about this, but I do think that, you know, at least what I try to tell the community is that every patient should be seen in academic center at least once for the full staging.
I would say for just like from a community or from a dermatologic perspective, anyone who presents with erythroderma should have flow cytometry as part of their workup. So some people will present to dermatologists red head to toe. And so typically they'll get a skin biopsy, and skin biopsies can be difficult to interpret in that situation. But in terms of making a diagnosis of something like Sezary, it's actually easy to do with flow cytometry. It can be very difficult to do with a skin biopsy. So flow cytometry is very important when patients present with erythroderma, especially.
I would totally agree. I would just add sometimes you would see a patient with only one spot, and that's extremely rare. You know, one spot of mycosis fungoides, nothing else, the first occurrence, and you think, oh, I'm happy, I'm gonna cure it with radiation therapy. But you do that flow cytometry, and it's on the flow, which means it's systemic, right? So I think everybody kind of deserves flow cytometry at diagnosis, especially if you think it's going to change any management.
Great. Thank you, doctors. We have one that's online here, so we'll let Autumn read that question.
Okay, thank you. So what they're asking is, what have you found as your most successful ways to treat Sezary at this point?
So this is a very nice question. So actually, you know, I wish Dr. Glass is here. He can tell you experience before MOGA and after MOGA. Really, after MOGA melisumab really changed how we look at the disease process of Sezary syndrome. So the way we treat disease, as many of you guys know, the reason that we never really achieve CR in cutaneous T-cell lymphoma is that when we grade the response, we grade it based on different compartment, right? You can have the response in the blood, you can have the response in the skin, and you can have the response in the lymph nodes. And different drugs actually have different efficacy in each of the compartment. And in Sezary syndrome, we say the reason people are itching red on like top to the body is because, not because of there's a lot of cancer cells in the skin, it's because of there's so much cancer cells in the blood, it's secreting cytokine to make patient all red and puffy. And the reason is because of sometimes if your dermatologist take a skin biopsy and they miss the diagnosis of Sezary syndrome, it's not their fault because there's very little cancer cells there. So sometimes Sezary syndrome is harder to diagnose in a skin biopsy than mycosis fungoides. And the reason I'm saying mogamulizumab really changed the paradigm of this is that mogamulizumab actually caused, even though the overall response is not very high, like you saw the slides about 30%, but in my experience, like almost 90% of patients will have a good response in their blood, and especially when they have MOGA related rash, like they really have a great response in their blood. Then what we're dealing with is, again, the disease in the skin, right? And that's hard to treat. That's harder to treat, in my opinion, than the disease in the blood. So then, we do a lot of skin-directed therapy. We use additional chemotherapy. The large cell transformation was the hardest, in my opinion, in the treatment paradigm here. So for the Sezary syndrome patient, I say the treatment are based on, like, the initial treatment, how I treat it, are based on two things. One is the burden of the disease. If you have very little, not a lot of burden of the disease, we usually start people with ECP. And if their disease are like a lot of burden, then we start with ECP and then potentially add, I guess before MOGA time, we add interferon or targratin as the treatment to augment that disease. But now, since I know if I give, a cycle of mogamulizumab, I'm going to clear the blood, I usually jump in directly to mogamulizumab.
And I think there is a study, MOGA ECP together right now ongoing. Yeah, so that's probably a good study, mogamulizumab and ECP together. So clear the skin and clear the blood,
Any response? Okay, thank you, doctors. Who's next? Who else has a question? Well, we have really done our job then. Well, let's go to another. I know we've got at least one more online. And then we'll see if anybody else has a question coming out of the next.
So we do have a few, but I don't want to monopolize the people that are in person. So we'll go through a few of the online ones. And then if anyone has one here, just go ahead and raise their hand. What is new in trials or on the horizon? Are there any treatments that we haven't talked about here today that you have anything you can share on?
So new drug on the horizon, there are actually a couple. There's new study called telemark study. Then that's for patients with Sezary syndrome, cutaneous T-cell lymphoma that progress through like 2 or 3 lines of therapy. That's one drug that's in horizon. I don't know. Do you think you'll get FDA approved soon? I don't think so. I think they haven't finished accrual, but we do have a small % of patients achieve a complete response in the patient that tried every single therapy. There is a medication called Lymphir that just got FDA approved. It's an immunotoxin where they basically deliver it's like a targeted therapy, but they add a little bit toxin to the targeting agent and then direct to the skin. And then that new drug actually has a better side effect profile than its previous version called Ontac, and that's FDA approved. And I think, if I'm correct, they're probably going to be commercially available early next year. As far as trials are concerned, we have a trial at Moffitt. So that's for patients with mycosis fungoides that has blood involvement of the disease. Remember, we're saying that if you have disease in the blood and you don't take care of it, then eventually it's going to repopulate your skin. You're going to have the disease come back. So the trial is aiming using mogamulizumab earlier, trying to clear that disease in the skin with the hope that clear the disease in the blood with the hope that the skin will get cleared and you're going to achieve a longer term remission. Other medication in line. I think there's another immunotoxin that's potentially starting. And then Durva, the immune checkpoint blockade with the Revlimid, the data actually look pretty good. So we're going to see at this ASH to see like what the real the study detail is, and then use that to base on our treatment. And then as far as large cell transformation is concerned, there's a lot of new anti-CD30 targeted agent with CAR T, with bispecific. I think that's on horizon for patients with large cell transformation.
Now, I would just say there are a few studies she mentioned that kind of is somewhat specific for CTCL, but there are multiple phase 1 studies that include patients with CTCL, but also other peripheral T-cell lymphomas and other non-Hodgkin lymphomas. So those might be available for patients, in different institutions. So always ask about clinical trials.
And there's actually one trial, if I forgot to mention, is that I think we're trying to open at USF and Moffitt. It's a new cream that you use with phototherapy to enhance the phototherapy absorption to the skin. And that's a trial. I think it should soon be open. Yeah, let me Dr. Glasses here.
Oh, I'm coming.
We have a new inside window.
Anyone in the room? Okay.
Thank you.
So another question regarding what I read and hear in some of the support groups that I'm in, is I'll hear fellow CTCL warriors say, yay, I'm in remission. I don't have to get treatment anymore. And that causes me confusion because at my treatment center, my doctors, and I ask my doctors, why do I see that? If there's no cure for this, why are there patients out there who literally stop treatment, whose doctors are stopping their treatment because they're in remission? His response to me is, Sheila, I really can't answer that question. What I can tell you is that we will never stop your treatment, but this is what is working and you're on a maintenance dosage of it and we're going to rock with it until if your body stops responding to it, we'll find something else. So they always use the term indolent with us. They never use the word remission. And I don't know if that's just a play on words or the psyche on what we think is happening when our doctors tells us that it's in remission or not. But I think it causes a lot of confusion.
Let's clear that confusion. Okay. So, the word remission means that disease is not showing on the skin or scans or whatever, but it never equals cure. So let's just move to the aggressive lymphomas for an example. Aggressive lymphoma is always that the aim is to cure. Now we treat it, for example, diffuse large B-cell lymphoma, we treat them with chemotherapy, 6 cycles, they are in remission, meaning we don't see that on the scans any evidence of lymphoma. Now, it takes 5 years in remission to call it a cure. Okay, so indolent lymphomas, they are very treatable, even CTCL. We put patients into remission sometimes. I use, as I mentioned, brentuximab earlier. I put patients into remission, then I stop treatment, and they stay into remission for some time, and then they relapse back. Now, the main thing, remission does not equal cure. Okay, so you can be in remission, but does not mean you're not getting the lymphoma back after you stop treatment. And that, continuing maintenance treatment or not is based on your disease, and every patient is different. The behavior of disease is different. In some patient, you could stop it and not see the disease for a few years or a few months or a few days. It depends on the patient and their disease.
That's great. Dr. Sluzevich, do you have anything to add to that?
Especially sort of limited diseases comes up with phototherapy. Should you be on phototherapy continuously? Should you take breaks? And, studies have shown if you clear with phototherapy and then you take a holiday, sometimes people will have a remitted period of up to a year and then they begin to relapse. And so sometimes patients prefer to be on maintenance. I'm being treated. I'm keeping this clear. Other patients, the burden of doing phototherapy, it's nice to be off of it. I know I've responded before. If I restart, I'm likely to respond. So a lot of it is patient preference, but I think, the framing of remission versus cure, like you mentioned, that's an important distinction to understand.
Yeah, I agree totally. I think the disease stage is what determines like whether or not you need the maintenance therapy and how easy it is to get you to remission, right? Say if you're stage 1A and then it's couple like six months of phototherapy and you got remission, maybe it's okay for you to be not on any treatment and then potentially later when disease come back, just repeat the treatment again. But say if a patient with Sezary syndrome, right, you know that after a couple lines of therapy, there's not much left to do, then, well, not much left, there's not much available that has a good response rate, then we highly recommend to keep people on some form of maintenance therapy if it's possible. Or if patient, even with early stage disease, say if it takes a lot of effort to get to that remission, right, they have to be on interferon, taggratin plus phototherapy for 6 or 8 months. Then after their skin is completely cleared, I prefer to put them on something so the disease doesn't come back. Well, so the disease, the disease because of the incurable nature will come back, but you try to prolong that remission period for as long as you can.
Wonderful. Thank you.
Well, first of all, thank you so much for all your information. I am the wife. But oh my God, learned a lot. I had heard a lot of the terminology from his doctor, which is a super friend. But today, it's like I can connect everything of all the stuff we've learned throughout all these years. But I have a question about why is it that the patient, when they do when they check the blood, it doesn't come out in the blood, but every time they do the biopsies, he's had different biopsies, it always comes out positive as MF in the biopsies.
I mean, the blood is clear, but the skin is, not all, most of CTCL actually, they don't have a lot of blood involvement. So that's why we check it early on, like a diagnosis. So we have a baseline. If he didn't have it, he didn't have it. It doesn't mean he will or need to have it to be diagnosed with MF.
But then it's normal for it to appear in the skin in the
Yes.
biopsies, but not in the blood?
You're right. It's not, the disease itself is not normal thing, right? But
Right.
it's very common
Common?
that you see this, mycosis fungoides without blood involvement. It's very
Oh.
common.
Always had that
Yeah.
concern
Yeah,
about
it doesn't, so the T cell, the immune cells in your skin doesn't necessarily have to travel through the blood to the other parts of your other skin. It actually can just travel directly, whether it's through lymph node or just certain side directly to the other side. So, so yes, you can have skin only disease. And that actually direct what treatment we're going to use really.
Okay. Thank you.
Why is he getting so many biopsies?
Well,
That's my question.
Well, no.
We already know what he has, so.
I initially have only one, and then when I'm looking and checking my dermatologist, and I have 3 more spot, she said, "Let me check that out," because the first one was a punch biopsy, the other one was with a shape, yeah, and after that I was positive too,
They
but
needed multiple biopsies.
Yeah,
to
yeah.
Different. It started first as a little white patch.
Oh, so you have different morphologies.
yeah.
Okay.
But when I have one of my medication that was a IV chemo, and 2 months later, when I finished 6 cycle, the cancer was faster. They grown up more, and I developed 12 tumor
From 12, after I finished that medication, I began to do other medication. There was 16 more. And then something happened, then the stop reduced from 12 to 8, but it was like 6 months, nothing happened, nothing positive, nothing negative. That was like a stable. Now only one tumor is very, very, it's almost gone. But the reason why I'm taking this moment is not because of that, it's because we were always talking about this medication, they're very crazy names, all this stuff, but you never mention something natural, natural medication combined with this strong medication, because this is strong medication. And I did something very crazy because one day I have in my belly skin open wound, dripping water, and that was bad. That was real bad. And I remember I bought a medication for my dog for open wound, an anointment. It's natural. And I said, okay, let me try this because I'm desperate. That was Saturday. I don't want to call my doctor. The medication they give me it caused me more irritation. And I said, okay, and I applied that. My son have autism. And I said, I want to show him what I'm doing because he's going to be out of whack. And that was Friday. And that was Friday, Saturday, Sunday. He see me in the bathroom using the ointment. I said, what are you doing? Are you crazy? That's for animals. It's not big different between a dog and a horse and me. I don't care. But I showed the ointment to my doctor, and he asked me, what is this? It's a homemade ointment, and all the ingredients are natural. And that was disappeared, deletion in 3 days. Got better, no bleeding, no pain, no itching, and nothing in 3 days.
Well, congratulations. Yeah. Well, there are a lot of stuff outside we don't know because this is rare things sometimes people use randomly and it works. I'm not saying, I know much about it or not, but most of our, recommendations are based on things, we know based on trials. Now, sometimes people use something and they see significant response to it. We cannot speak to it because we don't have data to prove it. Yes.
Okay.
Okay. So he is the data. Okay.
Well, I think we've got another one online.
Okay, we have a patient who is joining us virtually that has a kind of variety of questions in regards to Sezary and the sun. So I'm going to kind of run through them because I think that they can all be addressed kind of together. Do you see patients who are not able to get in the sun or any UV rays? They must wear UV clothing, otherwise they get red and burned. Is there a history of sensitivity to sunlight and Sezary as a symptom? And then Sezary patients with erythroderma, majority of skin, and sunburn issues. So I think just overall, they can't seem to be out in the sun, period, and they have Sezary. And is this something that you've seen in other patients?
Erythrodermic patients frequently are sun sensitive. It's not like necessarily the sun will flare them endogenously, but because their skin is so dilated and they're so red, they will often become more heat intolerant. They're going to have a lot of symptoms. And that makes it difficult sometimes to introduce phototherapy with treating patients with Sezary. When we didn't have as many good treatments, we would actually try to push people into phototherapy because we were so limited at what we could do. So certainly some degree of sun sensitivity could be seen with Sezary. But again, it's always important to make sure we know what the cause of erythroderma is, so in that case, you would want to make sure patients who are erythrodermic could be erythrodermic for other reasons. And so you'd want to make sure that that was a confirmed diagnosis also. Not all erythrodermic patients are Sezary patients.
Thank you, doctor. Anything to add?
No, I agree. So for Sézary syndrome patient, you want to make sure the blood is controlled and erythroderma is better before you get into the sun, because they behave different, like mycosis fungoides, where we say you treat with phototherapy. Later on, they might be better. Like once the erythroderma is controlled, and they can go out to the beach a little bit more. And then even in some patients with Sézary syndrome, when their counts are better, their erythroderma is going away, and they only have a little bit skin disease, we can treat with phototherapy. So, but the key for Sézary is that blood has to be controlled first.
Thank you. Anyone else? Oh, got another one in the room. We'll come back to the audience in a second.
I'd like to also thank you all for making yourselves available today. This is extremely enlightening and educational, and I can mimic like a lot of people I've talked to. It was 8 years before I was diagnosed properly. So again, thank you for the work that you do. My question would be, is there any data that correlates or defines or suggests a COVID shot for persons with a CTCL?
Like causing CTCL?
So, yes, so a COVID shot, is it recommended, or it's neutral, or I know the COVID when I'm still currently a Moffitt patient. When I first went there, I was in the years ago when I was first diagnosed, and the immune system compromised with CTCL versus the COVID shot versus what do we know today? Is COVID shot follow-on vaccination recommended? What does the data tell us, and or opinions? Thank you.
Take it.
Yeah, I can give you opinions. I don't think we have much data. I do not think COVID vaccination caused cutaneous lymphoma. At least we do not have the definitive evidence to show that. But I think this twofold. So I recommend my patient to get vaccination, but the key is to get vaccination like maybe prior, if you're starting any systemic therapy, right? So if you're thinking about getting chemotherapy, you probably want to do it a little bit before, because if you get a COVID shot, you are expecting yourself to be protected from COVID, and you need your lymphocytes, your immune cells to be there to initiate that response. But after chemotherapy, usually the chemotherapy we give in cutaneous T-cell lymphoma are not that toxic, but I still consider them toxic. So I think it's totally okay, and I would recommend getting COVID shot. But knowing that this, because of your immune system are suppressed, you might not gain as much benefit as as a person without any lymphoma, because your immune system are down. But for patients with are not on any chemotherapy or just on a little bit targeted therapy or early stage therapy, I do recommend the vaccination, not just COVID, but also your flu shot and stuff, because you are considered to be a little bit immune suppressed because of the lymphoma.
Thank you. Any additional thoughts to add to
I would
the?
just say quickly, so over the last 5 years with the 4 or 5 years with the COVID, almost everybody got vaccinated, almost, and also almost everybody got COVID as well, right? But with these 5 years, we didn't see an increase, a significant increase in the incidence of different types of lymphomas with the COVID. So I would say, the incidence typically increases over time slowly. So there was no spikes with the lymphoma incidence based on vaccination or being infected by COVID.
Excellent. Dr. Sluzevich, anything?
I think that's the same. I think that, the COVID vaccine certainly has induced some controversy because it's not a traditional vaccine. I mean, it's based on this mRNA technology, and I think it is very clear that, there can be some safety signals not necessarily related to lymphoma that may be associated with COVID vaccines. And so I do think, in the medical community, we have to be open to that, and it has to be thoroughly researched, because people will not have confidence in public health recommendations if they don't feel that people in the medical community are not transparent. And I think as we look back on the COVID epidemic, it probably could have been handled in retrospect maybe a bit differently. And so I'm very optimistic that, as we move forward, that these things will be, investigated in a transparent and open way.
Wonderful. Thank you. We have another one coming from online.
Yes, thank you. It's a little bit of a multi-part. Again, the questions were asked, and then there was a follow-up to something someone had already answered, is how do you know when MOGA is working? And do you add methotrexate to MOGA for it to work better? And then they were also asking, what is ETC? Because I believe someone mentioned ETC in an answer. If not-
ECP.
Oh, ECP. Okay.
Okay, got it. All right, what's the first question? Okay,
How do you know if MOGA is working?
Oh, okay.
And does it work better if you add methotrexate?
oh, okay, got it. How do we know MOGA is working? That actually is a very easy question. So we do peripheral blood flow cytometry, and I usually show my patient, this is your number before the treatment, this is your number after the treatment. You can see significant decrease in the number, so you know MOGA is definitely working in the blood compartment. In the skin, you know it's working because the erythroderma, or this swelling and redness kind of calm down. That's when you know it's working. Adding methotrexate to for mogamulizumab, this is actually interesting. So, one of the biggest side effects with mogamulizumab is mogamulizumab associated rash, and we usually treat it with steroids. And but if patient is refractory to steroids, sometimes people actually add a little bit methotrexate with the hope that it can help. Actually, I think this ASH Stanford is going to have a poster presentation on adding in some of the patients with MOGA rash that's not responding to steroids, they actually use methotrexate. In terms of combining them in the beginning, like just do mogamulizumab and methotrexate, I don't think that's been studied, so I cannot say whether it worked better or worked less. But you are actually expecting a higher toxicity, though. So so that's something I don't have data on, but it does. But we try to do ECP plus MOGA on a good handful of patients, and it worked pretty well. So that's what I usually like. One issue with MOGA is MOGA is not approved as first-line treatment for Sezary syndrome, so you always want to try something. And then, in my experience, the one of the treatment that's most efficacious for CTCL, or very efficacious for CTCL, it's ECP, and I'm a little privileged at Moffitt because I can send all my patients to ECP, so that's what I do before MOGA. So I don't know, my experience is a little biased in there, but I do think maybe it's worth to look into MOGA combining with other agents. Yeah.
Anything
Just
else?
say ECP, extracorporeal photophoresis, and extra in the medical field is not more, it's outside. Corporeal is body, and then photophoresis. So basically you're taking the blood outside of the body into a machine doing the job and then return it to the body. Extracorporeal photophoresis.
Anything else? Any other questions in the room? I know we have at least one more online. Okay. I'll come right back to you, Sheila. One first.
I've been on light therapy for 12 years, and I'm almost 85 next month, and I'd love to go in the sun. I've had melanoma, many basal cells, many squamous cells. My wife wants to go to the beach and I tell her I can't be out in the sun because of my history, but I'd love to be in the sun. Where am I at on this?
So you go for phototherapy, you're on a maintenance dose, is that what you are?
I've been on 3 times a week for 12 years, but in the last year I've cut down to twice.
Twice a week.
And now the last 2 weeks, just 1 time.
Good, yeah.
I've tried to get off of it about once a year, and every
Mhm.
time I go longer than 2 weeks, it all comes back, and then I have to start all
Yeah,
over.
you don't want to do that, yeah.
And so I did have a period 6 years ago where I went for 3 years. In my trial, I just ended up not even getting any light therapy for 3 years, and it did come back, but that was 6 years ago. So the last
What's
3 years
your
ago.
energy level? What's your treatment duration? How long are you in the box for? Or do you know how much energy you get? How
I'm
long you're in the box for?
I'm in there for it always was about 2.5 minutes. Now I've been up to 3.5.
Okay, so it's still relatively low. Honestly, as long as you have good skin checks, you can periodically have some high intensity sun exposure. You're already actually hardened to UV because you have been chronically exposed. And so you're going to be resistant. And so if you want to do a beach day or something recreational with high intensity sun, it's not going to make any meaningful difference to your skin cancer risk relative to what you're getting with UV. And as long as you have the appropriate skin surveillance and skin checks because you have a melanoma history, you'll be fine. So I would say enjoy the beach.
Thank you, sir.
I was gonna say, we're going to the beach. I've got one more in the room and then we'll go to our online.
Now, this question is purely cosmetic. So I'm getting to an age now where I'm looking at Botox and some of those other things, but I've always been resistant because of my CTCL. And so are there any studies out there that says CTCL patients shouldn't get some of those, those chemical peels and Botox and all that stuff that make us look young and fresh?
So,
Right?
I can only tell you from I guess a side effect profile, some of the systemic retinoid we use does do get rid of the wrinkles, but that's not what we intended to use. I'll leave that.
I don't know anything about cosmetic dermatology, even though I'm a dermatologist. So I think theoretically it should be safe. Sometimes we talk about skin disease being Kebnerized, that if there's trauma to the skin, it induces that. We don't really necessarily see that with MF. So I don't see any obvious reason, but I don't know if anyone systematically looked at that.
Okay, thank you. This question that we have from online is a little bit different. They're curious if there's a database where medical professionals are entering treatment outcomes that they share.
Is a person willing to help? Is that
We can ask them.
Yeah, no, of course, there's database, at Mayo, there's database at Moffitt, we have about 2,800 patient database on cutaneous T-cell lymphoma. It's going to be a lot of work to complete the database because of you can see the treatment in cutaneous T-cell lymphoma are so complicated with multidisciplinary approach, but we're looking at newer ways of complete that that database. And we are, I think, the USCLC, actually are doing some kind of registry-based database. So national level, we have institution database, and we try to collaborate as well. All the cancer center in Florida, we try to put together database such as allogeneic transplant outcome in cutaneous T-cell lymphoma and other very specific things. Yeah.
Okay, thank you. Do we have any more questions in the room or online? This is your chance to get it in. I'm keeping an eye out on the virtual. We have one last call question. What is a recommended path to stem cell transplant with Sezary beyond being as clear of cancer as possible?
Can you repeat that question?
What is a recommended path to stem cell transplant with Sezary beyond being as clear of cancer as possible?
So, I have not done a lot of stem cell transplant for Sezary only in this in this time period. It's because of a lot of treatment that we have changed the paradigm for the Sezary syndrome. But sometimes when Sezary syndrome patients develop large cell transformation and they develop multiple large cell transformation, that's when we think about allogeneic stem cell transplant in those particular case, because we know they're very hard to get to a complete remission with the current available therapy we have. Other than, like, the goal is always a complete response. So sometimes we use chemotherapy, sometimes we use total skin radiation. But to be honest, getting a complete response in CTCL is very difficult, and having that response to last more than 6 months is even worse. So what we usually do is we give them some therapy to get to a partial response, and then right before, remember I said the blood is easier to clean out now, and the lymph nodes we can clean out with chemotherapy. The issue was the skin disease is very hard to control. So we'll do a total skin radiation like a couple of weeks before the stem cell transplant to get them into theoretically a CR before the transplant. But for Sezary syndrome only, say if they don't have large cell transformation or significant disease in the blood and they respond very well to the therapy that they're on, we usually do not do transplant like right away.
So the patient, I mean, should have a disease that is refractory and now in complete remission, and we do not expect this complete remission to last for a very long time. That's why we would probably take him to transplant. And also he should have a donor. So finding a donor sometimes is an issue. That's part of the path into an allogeneic transplant.
Yeah. And we consider it for younger patients sometimes a little bit more, just because of their ability to tolerate the transplant, and also we're hoping for a cure really for younger patients.
Dr. Sluzevich, anything to add? Okay, great. Oh, yep. One more. Okay, good job.
I know I've got lots. I was always that student. Is there any data out there that gives any light into why CTCL is more common in African Americans?
I actually want to study that. So
There we go.
yeah,
There we go.
maybe we should connect. So as far as I know, like there are epidemiology study to learn that African American develop a disease at early stage, like at early age and more advanced stage. And my experience, I do have very young African American patients with very aggressive cutaneous T-cell lymphoma. But in terms of, I try to look into everything I could, try to understand why, if there's anything in terms of the disease biology, do they have different mutations? Is it the immune environment that's different? I don't think there are great data in there. Sometimes people think is that the melanocytes kind of protects the skin from the sun, and then we know that sun helps with the cutaneous T-cell lymphoma. That might be why. But I think the answer is probably going to be very complicated, and until we look at the immune environment together with the genetic marker of the tumor, we will not be able to understand why. And, you know, the key is to understand the underlying biology difference, and maybe the treatment approach should be kind of tailored to whatever is underlying in terms of genetic mutations and immune environment. Yeah, but that's something I definitely, you know, will love to have someone that advocate for like research project like this. So
We're in. Any other perspectives on that? Yeah. Oh, wait, I'm coming. Yep.
What is your data on Hispanics? Is there same as Afro-Americans, the more larger amount of people with it?
I would say and especially the Hispanic population is also within the Hispanic population. There's like multiple, subpopulations. So it's very difficult to give an answer to that, I would say, based on what we have. I think the last decade and probably part of the next decade is kind of more like epidemiology, trying to prove that these populations have more incidence of the disease. But just to answer also the previous question, we don't know why yet. And that happens in many types of cancer, colorectal cancer, multiple myeloma. But I think probably the next decade is, with all the AI things and all the big databases, hopefully we can answer these questions or start answering these questions.